Hello, my name is Eric Neira and I'm going to talk about driving pressure in the ARDS, or commonly known as Adult Respiratory Distress Syndrome. The common signs and symptoms of adult respiratory distress syndromes are tachypnea, dyspnea, retractions, hypoxia, tachycardia, and crackles. The persons that suffer from this syndrome, they are commonly attached from a ventomatic. The common causes of this syndrome are massive trauma, severe respiratory disorder, prolonged mechanical ventilation, hemorrhagic shock, fat emboli, and septic condition. What do we know about dyspnea? Let's see something.
Time start now? Alright, so in 3 minutes, I hope that I can summarize what we do and pique your interest a little bit. So, in my lab specifically, I study the symptom of dyspnea. So for those of you who are not familiar with that, it's another more technical term for breathlessness or shortness of breath. And really, the technical definition is that it's a subjective experience of breathing discomfort that people commonly will experience during physical activities such as exercise. So we're all familiar with this type of sensation. What's important is that this symptom is actually a common and very debilitating symptom in patients with chronic heart or lung disease, and particularly in the context of exercise. So you have individuals who've smoked for a long period of time, they develop emphysema or bronchitis, and they become extremely uncomfortable. It limits their activities of daily living and really leads to an impoverished health-related quality of life. So here I have a gentleman with COPD, and on the right side there you see reasons for stopping exercise. So we bring a large number of individuals into the laboratory, we put them on a bicycle, we ask them to exercise as long and as hard as they can, and when they're completely at their point of exhaustion, we say, why did you stop exercise? Your breathing discomfort, your leg discomfort, a combination of the two, or something else. And you can see that as many as 63% of these people complain of shortness of breath as the primary reason for them stopping exercise. So that anchors it from a clinical perspective that this is a very important symptom to understand so that we can effectively manage it and treat it. So a brief neurophysiology of this symptom. In the most basic sense, breathlessness really reflects the relationship of the drive to breathe and how well our respiratory system is able to accommodate this drive. So when healthy individuals, like presumably everybody in the room, you start exercising on a bicycle in the laboratory, we have increases in the drive to breathe and an appropriate response to the respiratory system in terms of how much volume we breathe, how quickly we breathe, and so on and so forth. And under these conditions, we get a normal awareness of an increase of our breathing. It may or may not be inherently uncomfortable, but we definitely notice our breathing. However, you take an individual who, say, has developed through bad habits, emphysema or bronchitis, and what happens is that they have a very accelerated drive to breathe. So there's a lot of drive going from the brain to the respiratory muscles, but because of the sickness of their lungs and their airways, they can't essentially do the work that's necessary to match it. And under these circumstances, people become incredibly symptomatic and incredibly short of breath, and they're limited in their exercise at levels of intensity that we take for granted walking upstairs. So in our lab, we use exercise on a bicycle as a stress. We measure the physiological responses using a metabolic cart, as you see there in the second white picture. We're unique in that we have about a meter-long catheter that we push through the nose down into the stomach and the esophagus, which measures how well the respiratory system is actually responding to a stress. And there's one of my undergraduate research students who's actually performing a technique, a procedure, with a catheter actually pushed, and it's down about 55 centimeters into his body. When we record these measurements, we actually do recordings of the electrical activity of the diaphragm. So I'll show you 5 channels here, and the esophagus and the stomach and the pressure in the esophagus, the gastric pressure, and how much air is moving into and out of the lungs. And so you can see that an individual at rest, you can see that the brain is really not sending all that much information on a per breath basis, a little bit of pressure being generated and a little bit of flow. But as we move into moderate and more strenuous exercise, you can see that the activation of the breathing muscle grows, the muscles begin to do more work, and particularly near strenuous exercise. So we can see how appropriate these responses are. Once we've quantified these things, we can relate our sensation to different physiological responses. and compare these responses across individuals or across groups. So, I know I'm over my time, but just to give you a sense of how we're applying these techniques, we're currently doing studies looking at patients with COPD. We're mimicking disease by essentially restricting the thorax using a chest wall strap. We're binding the abdomen to essentially increase the pressures in there. We're doing studies related to obesity, and we're comparing responses between healthy young men and women. Thank you.
Let's see what ARDS.
Welcome to USMLEFasttrack.com. The section we're going to talk about today is from First Aid for the USMLE Step 1, 2013 edition.
Page 556. What is acute respiratory distress syndrome? Acute respiratory distress syndrome is a life-threatening lung condition that prevents enough oxygen from getting to the lungs and into the bloodstream. What are all the causes that can lead to acute respiratory distress syndrome? Acute respiratory distress syndrome can be caused by trauma, sepsis, shock, gastric aspiration, uremia, acute pancreatitis, or amniotic fluid embolism. Describe the pathogenesis of acute respiratory distress syndrome. In acute respiratory distress syndrome, one of the causes that we just mentioned is going to cause diffuse alveolar damage and increase in alveolar capillary permeability. Now, when there is an increase in the alveolar capillary permeability, there is going to be a leakage of protein-rich material along with neutrophilic substances into the alveoli. This protein-rich material is going to cause the formation of the intra-alveolar hyaline membrane, and the neutrophilic substance is going to cause damage to the alveolar wall. So basically, in acute respiratory distress syndrome, there's going to be high amounts of fluid that will end up getting into the alveoli and cause damage there.
For more information on this topic, click on the link in the description section below. For a full USMLE Step 1 review, be sure to check us out at USMLEFasttrack.com, where we help you review the entire first aid for the USMLE Step 1 with high-quality videos and hundreds of detailed pictures for a better understanding of the material. So to learn from the best USMLE review book, be sure to check us out at USMLEFasttrack.com.
Well, now that we know a little bit more about dyspnea and ARDS, we can say that ARDS is a severe life-threatening reaction to injuries or acute infections to the lung. These infections can be direct or indirect. Alveolar and vascular functions of the lung are disrupted by inflammatory mediators. ARDS is characterized by bilateral pulmonary infiltrates and severe hypoxemia in the absence of evidence for cardiogenic pulmonary edema. Risk factors. These conditions are divided into two categories: those that cause direct lung injury and those that cause indirect lung injury by activating a systemic inflammatory response. In the direct lung injury, we have the common causes that are pneumonia and aspiration of gastric contents, and less common causes like pulmonary contusion, fat emboli, near drowning, inhalation injury, or reperfusion pulmonary edema after lung transplantation or pulmonary embolectomy. And in the indirect lung injury, we have the common causes like sepsis and severe trauma with shock and multiple transfusions, and the less common causes like cardiopulmonary bypass, drug overdose, acute pancreatitis, and transfusions of blood products. Signs and symptoms. The first documented description of ARDS occurred in 1967 by Ashbach and College when describing the clinical features of 12 patients: severe dyspnea, tachypnea, cyanosis that is refractory to oxygen therapy, loss of lung compliance, diffuse alveolar infiltration seen on chest by X-rays.
When a person's lung is injured to the point when it becomes ineffective to do its basic functions like moving air in and out of the blood, the condition is known as acute respiratory distress syndrome, ARDS. The condition develops rapidly and can be life-threatening. It was recognized by doctors first in the year 1967 and was initially known as adult respiratory distress disorder. but after it was found that the condition can also occur in children ages 1 and older, medical professionals now refer to it as acute respiratory distress disorder. Other names for ARDS are acute lung injury, non-cardiac pulmonary edema, and increased permeability pulmonary edema, and it has been mentioned as stiff lung, wet lung, and shock lung in the past. Symptoms of ARDS. Mayo Clinic says, the signs and symptoms of ARDS can vary in intensity, depending on its cause and severity. They include severe shortness of breath, labored and unusually rapid breathing, low blood pressure, confusion and extreme tiredness, low oxygen levels in your blood, which can lead to organ failure, and symptoms such as rapid heart rate and abnormal heart rhythms. Some symptoms of ARDS may occur depending on the cause of the disorder. So, if pneumonia was the reason behind a person's ARDS, they may experience chest pain and fever along with other symptoms of it. ARDS is a medical emergency, and if a person experiences its symptoms, prompt medical help and treatment should be looked for, absence of which can lead to death in no time.
Let's see the pathophysiology. The pathophysiology has 3 overlapping stages: exudative, proliferative, and fibrotic. Exudative stage. The direct or indirect lung injury initiates the release of cytokines and other inflammatory mediators. These cytokines activate neutrophils and monocytes, which adhere to the pulmonary capillary endothelial surface and migrate into the interstitial and alveolar spaces. Neutrophils produce oxygen, radicals, and proteases that can injure the capillary endothelium and alveolar epithelium. Neutrophil arachidonic acid metabolites can cause alteration in vascular permeability. Endothelial and epithelial injury. 2 separate barriers from the alveolar capillary barrier, the microvascular endothelium and the alveolar epithelium. Injury to the alveolar lining cells also promotes pulmonary edema formation. The normal alveolar epithelium is composed of 2 types of cells. Flat type 1 cells make up 90% of the alveolar surface area and are easily injured. Damaged 2 type 1 cells allow both increased entry of fluid into the alveoli and decreased clearance of fluid from the alveolar space. Cuboidal type 2 cells make up the remaining 10% of the alveolar surface area and are more resistant to injury. Their function includes surfactant production, ion transportation, and proliferation and differentiation to type 1 cells after injury. Epithelial injury. Damage to type 2 cells results in decreased production of surfactant, with result decreased compliance and alveolar collapse. Fibroproliferative phase. These early events are followed by the proliferative phase, which develops 2 to 7 days after initiation of lung injury. Proliferation of type 2 pneumocytes, early fibrotic change, and mesenchymal thickening of the alveolar capillaries. In some individuals, the proliferative phase progresses to a fibrotic stage, 2 to 4 weeks, that is characterized by widespread formation of collagenous tissue by fibroblasts causing thickened alveolar septa. A prolonged period of ventilation, perfusion, mismatching, and diminished compliance of the lung. Pneumothorax are common.
So let's go into our progression of Ards here, okay? So with acute respiratory distress syndrome, we have a few things going on here, okay? In the early stages of acute respiratory distress syndrome, we have pretty much fluid accumulating interstitially in the pulmonary spaces. So interstitially means it's not in the lungs yet. It's actually surrounding the lungs. All this fluid, all this blood, all this pus, white blood cells is surrounding the lungs. So fluid in interstitial spaces, we call it. You have next is your second phase, and second phase through your fourth phase is called your late. So this late phase, that fluid now shifts into the alveoli. So now there's just wet alveoli, and you can hear it with crackles called crackles of the lungs. So your patient can be in Ards, but they might be in an early stage where their lung sounds perfectly clear, and they don't sound like they are having any respiratory problems. Maybe they're having decreased breath sounds, but it sounds like, there's no crackles. It doesn't sound wet at all. 2 days later, your patient might have now fluids in this alveoli because the alveoli themselves have been damaged. Next 10 days now, oh man, did I mess up? Oh yeah, no, it's okay. Next 10 days, you have fluid that has increased in the lung itself. So you have pulmonary fibrosis, which just is a fancy term for your lungs themselves have almost been like burned. It's almost like you've taken a lighter and burned a piece of paper. Now, how do you go back and unburn a piece of paper? You can't do it. You can't just stick a Band-Aid on your homework after you've burned it and think it's going to be better. So patients who have progressed into the third and fourth stage of Ards usually do not come out. I'm not going to say usually because they will constantly, chronically have burned lungs. This might even lead to an entire systemic inflammation, also called SIRS. But Ards is really just an inflammation of the alveoli itself, and once this progression happens, you can have inflammation of the entire respiratory tract. When this inflammation happens, all the fluid that's on the interstitial spaces on the outside of the lung tract will actually shift into the lungs itself, causing a breakdown. So not only are we having total inflammation of the respiratory tract, we're also having and could lead into multiple organ disease syndrome, what's called MODS. Multiple organ dysfunction syndrome. So, really, when I'm talking to you guys, and hopefully all my lectures, you guys understand that oxygen is the money of the body. Without oxygen, you guys cannot live. Without oxygen, nothing in your body can live. So, in the fourth stage, your PaO2 is less than 60. So you're very, very hypoxic. It should be at least 80 to 20. Your pH level is less than 7.30, meaning that you're very acidic. Why are you acidic? Because all that CO2, all that waste that has been, basically your body has dropped off oxygen to the distal portions of the body, to the organs, and your body's trying to transport that CO2 back to the lungs and breathe that CO2 out. So, how is that CO2 going to be breathed out if your lungs now are pretty much screwed? Your lungs are pretty much charred. There's no exit for your CO2 to get out. So you're going to be very acidic. You're going to have high carbon dioxide in your bodies. So your CO2, your carbon dioxide, is going to be greater than 50. Really, really high acid. Your pH is going to be high acidity as well, leading to no oxygen exchange. So we're holding on to that CO2. We're not exchanging it for oxygen anymore because we burned pretty much our lungs and we burned our production line of exchanging oxygen. So it's almost like if you go to the supermarket or go to the farmer's market and you want to exchange money for fruit, right? Let's just say someone burned down the entire farmer's market. There's no more products anymore. You're not going to be able to exchange your fruit for your money. If someone burned down Walmart, if someone burned down the next grocery store, you're not going to be able to exchange anymore. Does that make sense? You're not going to be able to exchange that carbon dioxide in the body, and you're not going to be able to get that oxygen. So what we usually do is the patient will be on a vent for the rest of their lives, and we're trying to breathe for them, very minimally. So, if we catch it before your patient goes into pulmonary fibrosis, or the scarring of the lung tissue itself, it really depends on how far along this pulmonary fibrosis is. Can we catch it? Can we reverse some of the side effects? Can we give your patient something that will help decrease the inflammation of your alveoli and your respiratory tract? So let's talk about some of the therapeutic modalities of what we do with patients in Ards. Let's do it.
Well, let's see this little video. This ARDS is just so common here in Ecuador and common all around the world. We need to know what we should do and what we need to be capable of doing when something like this happens.
Hey, girl, help me!
Mom, are you alright? Mom!
Worldwide, over 2 million patients will be diagnosed with acute respiratory distress syndrome this year. In the United States alone, about 200,000 patients will be diagnosed with Ards. About half of those patients will die.
Ards affects men.
Ards affects women.
Ards affects children.
Ards affects families.
Ards affects everyone.
It does not discriminate.
Ards is a syndrome that occurs after one of 60 known precipitation causes. It attacks the lungs and renders them to breathe ineffectively. After admission to the hospital, Ards strikes within 24 to 48 hours. Within 2 days, the patient's lungs will show a whiteout on chest x-ray. This means that they are in complete distress and not functioning properly. Ards is always a critical medical condition that requires a team of health professionals. Patients always require mechanical ventilation, which leaves the body vulnerable. Complications are quite common and often deadly with Ards patients. These complications can include sepsis, hospital-acquired infections, and multi-organ failure. Patients can be hospitalized for weeks, often months. Ards not only affects the patient, Ards affects everyone they love and everyone who loves them. The toll of watching a loved one with Ards is traumatic. Families are devastated and lost. Caregivers often suffer from depression or post-traumatic stress disorder after what they've seen. Survivors of Ards also suffer from depression or post-traumatic stress disorder after what they have endured. Most people have never heard of acute respiratory distress syndrome until they or a loved one is diagnosed. It's overwhelming not knowing what's happening to your loved one. That's why the Ards Foundation was created. At ardsusa.org, you can find a wealth of knowledge from medical professionals and stories about this awful syndrome. In December 2000, Eileen Zaharias, an Ards survivor, and Paula Blonsky, who lost her sister to Ards, created the Ards Foundation. The Ards Foundation offers informative literature, support to families, support to patient survivors, and helps to fund medical research. The Ards Foundation lets everyone in the Ards community know that they are not alone.
It's a reaction of the lung to a variety of different insults, either after a trauma like a car accident or a severe bloodstream infection or pneumonia. And in many ways, the lung goes into shock, and then people require life support, mechanical ventilators, and generally end up in an ICU for a long period of time.
When I was 33 years old, I was struck down with lower back pain, and literally 2 days later, I was in the hospital fighting for my life. I ended up in the hospital for 9 weeks. I was on a vent for 8 weeks. I was in a drug-induced coma for 4 weeks.
Eileen was a young woman who had a community-acquired pneumonia that was probably misdiagnosed early on, came in and developed ARDS.
Back in 1998, my sister had some minor surgery. Approximately 2 or 3 weeks later, her wound wasn't healing, it was just minor surgery, and she developed a high fever. So we took her to the ER within 2 days. She told us she couldn't breathe. During the lung biopsy, her lung collapsed, and that's when they put her on a respirator. And she never came off the respirator. She was in the hospital for 8 weeks, during which time they were doing various tests, and we also found out she had leukemia. The doctors were confident they could cure the leukemia if they could just get her through the ARDS, but we never had that chance.
My chances of survival were predicted as slim. My family was told that there was no hope.
But ultimately, she did recover, and she had her tracheostomy taken out, and she rehabilitated, and she has survived to create the ARDS Foundation.
The foundation was created initially for one purpose, and that purpose was to create one informative brochure that we could get out to families, loved ones, patients, explaining in plain English what ARDS was. There was nothing else out there at the time that I was sick or our co-founder's sister had been diagnosed with ARDS.
When my family and I were going through the crisis with my sister, we searched for information, and there just was no answers out there. We asked the doctors, we asked the nurses, and we didn't want anyone else to have to go through that lack of information, not knowing what their loved one is going through. So Eileen and I started the foundation to get that information into the hands of the family that need it so much.
The best place for family members to gather information about ARDS is the ARDS Foundation website, which is ardsusa.org. That's a good place to start because there are links to other websites that are very useful, including the National Institutes of Health's ARDS Clinical Trials Network site and other websites.
For more information or support, contact the ARDS Foundation at ardsusa.org or 312-749-7047.
And together we can breathe easy again.
Well, this was interesting. Thanks for watching.